Welcome. Acute spinal trauma refer to an injury to a spinal cord that happens suddenly. It can be a very serious condition as it can damage the nerves that carry messages between the brain and the rest of the body. This can lead to loss of movement, feeling, and even paralysis. There are many different causes of acute spinal trauma, including car accident, falls, diving accident, sports injuries, violence. Symptoms of acute spinal trauma will vary depending on the severity of the injury and the location of the injury. Some common symptoms include pain in the back or neck, weakness or paralysis in arms or legs, numbness or tingling in arms or legs, loss of bladder or bowel control, difficulty breathing. Acute trauma either in the form of direct blow to the spine or the application of excessive rational or compressive force applied to the spine can result in injury to virtually any structure. The structure most vulnerable to acute trauma are the annulus fibrosus of the intervertebral disc, the end plate of the intervertebral disc, and the vertebral bodies. Diagnosis of the acute spinal trauma: take a medical history and ask about the patient's symptoms, perform a physical examination, order imaging such as X-ray, CT scan, MRI. Treatment for acute spinal trauma will depend on the severity of the injury, medication to reduce pain, surgery to stabilize the spine, rehabilitation to help the patient regain movement and function. Disc herniation: when compressive or rational forces are applied to the spine, the fiber of the annulus fibrosus can be stretched beyond their elastic capacity, tear. If these tears are oriented in a radial fashion, the nucleus pulposus may migrate through the tear, causing a protrusion of the disc beyond its natural border. This can occur as an acute process in the healthy disc given sufficient force. Degenerative discs that already have some degree of annular tearing, usually in circumferential pattern, have less elastic protoglycan and are less able to withstand these forces. If there is a disruption of the posterior longitudinal ligament, nuclear material can extrude through annulus, narrowing the diameter of the neural canal. If the disc herniation protrudes posteriorly in the midline to narrow the central canal of the spine, compression of the cauda or spinal cord can occur. If the disc protrudes laterally, it can extend into the lateral foramina, encroaching on the nerve root. Compression fracture: a direct axial force applied to the spine, especially in flexion, can result in collapse of vertebral body. There is disruption of the intrinsic structure followed by the healing and the healing of the bone. If severe, this compression fracture can force spicules on the bone or the entire vertebral body to move posteriorly, encroaching on the central canal, or laterally encroaching on the neuroforamen. As a result of margin forces, the end plate of the vertebral body may collapse, allowing herniation of the nucleus pulposus into the vertebral body. This has become known as chromal node. Bony fracture of the vertebral body are well visualized on X-ray, and the edema associated with healing is visible on MRI scan. This herniation, however, is not seen on standard X-ray and require either MRI or CT scan to be visualized. Radial tears and protrusion of the nucleus into the tear can be visualized by injecting a radial opaque dye into the disc, which can be visualized on X-ray as a discogram. These changes are more clearly seen on post-discography CT scanning. Electrodiagnostic evaluation is often used to document injury or encroachment on the nerve root of the spinal cord. which occur as a result of this compression fracture. Sagittal TI with MRI demonstrating decreased signal intensity in the L3 vertebrae indicate the bone edema. Secondary to compression fracture. Compression fracture, lateral lumbar radiography in the patient with acute process, and the compression fraction L1, which collapse in the median of the anterior aspect of the vertebra. Here, a transverse section at the L5 S1 level showing a disc herniation, central encroaching on the central canal causing stenosis. One variety of vertebral body and the end plate defect allowing herniation of the nucleus pulposus of the vertebral body. MRIT1 with image revealed. This image revealed the herniation of the L3, L4, creating a scromal node or label hernia. Here, a patient's T2 with image post a discogram computed tomography sagittal deformation demonstrating scromal node. Axial MRI demonstrate a right-sided herniated nucleus pulposus. Demonstration of 3 differential imaging technique demonstrating right side lateral disc. Non-enhanced computed tomography of the same patient reveal increased signal density of the lateral disc. MRI demonstrates central disc extrusion L3, L4. Sagittal T2 MRI image of lumbar disc herniation L5 S1. The normal appearing right S1 nerve root. Sagittal 2 MRI with demonstrating lateral disc herniation L4, L5. Note the relationship between the normal appearing nerve root at L3, L2, L3 and the pedicle. Post-discograph CT demonstrating contrast extending through a confluence of annular tear into radial fracture, a radial fissure. Longitudinal section through the lumbar spine showing large disc herniation. L4, L5. The posterior changes in the form of a regular surface. Longitudinal section through L3, L2, L3, L4 showing degeneration and disruption of intervertebral disc. Bone to fracture in the end plate and the superior aspect of L3. Sagittal T1 MRI demonstrating decreased signal density in L3 vertebrae indicating of bone edema. Secondary to compression fracture. Lateral lumbar radiograph in patient with osteoporosis and a compression fracture, while one with collapse and wedding of the anterior aspect of cerebral body.